Hi everyone. We're just going to give it another minute. There's still a couple of people joining, and then we'll get started. All right, just for the interest in time, I think we're going to get started. Hi everyone. Thank you all for joining us today for another Revive seminar. Just a warm welcome to all of our Revive members, as well as all of our guests joining in today. My name is Keisha de Gouveia. I'm a research medical officer on the Revive trial, based at the University of Cape Town in South Africa. And for those of you who are joining us for the first time, I just want to explain that we use these seminars as a platform to discuss some important topics related to advanced HIV disease, as well as related clinical trials. So we host these webinars monthly, and we welcome anyone and everyone who might be interested in listening in. So please do feel free to share the invite with anyone that you think might be interested in joining. And just before we begin, just some housekeeping rules. We will be recording the seminar, and so I'm just going to ask everyone to kindly keep themselves muted, and we will have some time for questions at the end. So please save your questions for then. You can put them in the chat in the meantime, or after the presentation, you can also raise your hand to ask your question. Okay, so we are just going to go through the agenda briefly. So first we'll start off with an overview of the Revive trial with the focus on trial progress and recruitment. And this will be done by the chair of the Revive Steering Committee, Professor Graham Menkes. And then following this, we will have our presentation by Dr. Daniel Sessay presenting on HIV in Sierra Leone. And then lastly, as mentioned, we will have some time for some questions and some answers as well. Okay, so I'll hand over to Graham now, who will just give us an overview of the Revive trial.
Thanks very much, Keisha, and welcome everyone to the session this afternoon. So just by way of background, I know that many people on the call are well acquainted with the Revive trial, but just wanted to put up one slide for those people who aren't yet acquainted with the design and the rationale for the trial. So the Revive trial is a pragmatic, multi-center, double-blind, placebo-controlled, event-driven randomized control that's funded by the Gates Foundation, and is addressing the hypothesis that among patients with advanced HIV, CD4 count of less than 100, starting or restarting antiretroviral therapy after an interruption, 4 weeks of azithromycin dosed at 250 milligrams daily will reduce mortality compared to placebo at 6 months of follow-up. So essentially, the rationale is that we know that despite antiretroviral therapy and despite the package of care for people with advanced HIV disease, mortality remains substantial for people who start ART with a CD4 count of less than 100 or restart ART. What we're testing is whether adding azithromycin to their treatment to prevent bacterial infections for the first few weeks of starting or restarting ART will reduce mortality at 6 months. And so the trial is enrolling adults over the age of 18 with a CD4 count 100 or less, and not with an active acute illness that needs to be managed first, and then they might be eligible for the trial. Patients are randomized to azithromycin or identical placebo for the first 4 weeks, and then followed up to the primary endpoint at 24 weeks when mortality is ascertained, and then further follow up to 48 weeks. So we plan to enroll a total of 8,000 participants across several African countries. And Elsa, can you go to the next slide? Ultimately, we have 13 countries who will participate in the trial. Across those 13 countries are planned 58 sites Currently, 6 of those countries are activated, have sites activated, and you can see listed there in green: South Africa, Sierra Leone, Nigeria, Uganda, Ivory Coast, and then the most recent country to have sites activated is Zambia. So there are currently 25 of the 58 planned sites activated, and you can see in the map which sites are currently recruiting, which sites are working towards activation. Next slide. And you can see that this provides an update on recruitment as of yesterday. And I just want you to focus on the third and the second last columns. The total participants randomized as of yesterday. The total is 917. And you know that in the country totals are shown above that: 168 in Nigeria, 284 in Sierra Leone, 279 in South Africa, 178 in Uganda, 7 in Côte d'Ivoire, and then Zambia, where sites have been recently activated, 1 participant enrolled, and we really want to congratulate them on starting. And then in the last 30 days, there have been a total of 97 participants enrolled across all of the countries enrolling, and that's really moving up towards our target of 200 participants being enrolled a month as we expand the number of sites enrolling. Next slide. And this just shows you the projected recruitment. We would plan to complete recruitment by the end of 2027. We initially planned a lead-in phase, which with a more gradual gradient in terms of enrollment, but around this time we are planning that the need for more accelerated enrollment as more sites come on board. And as I said earlier, the plan would be to go from 100 participants enrolled per month to 200 per month to meet our target by the end of 2027. So to date, we've been making good progress according to what we had projected. And the sites that are enrolling are doing a fantastic job in terms of the numbers that they're enrolling. But we will have to expand the number of sites, and that's clearly will happen once registration and approvals are in place in the additional countries. So thank you and congratulations to all of the teams that have been enrolling to date, and really great progress on the trial in terms of enrollments, but also in terms of the data completeness and participant follow-up. And just congratulations to everybody involved. And just to say, I'm really looking forward to Dr. Daniel Sessay's update this afternoon on HIV in Sierra Leone, from which I'm sure we will learn a lot. Thank you very much.
Thanks so much, Graham. It is very encouraging to see more countries and sites being activated. And again, just another big congratulations to Zambia for enrolling their first participant. And so next up, we have our main presentation for the day. So we have Dr. Daniel Sessay, who will be presenting on HIV in Sierra Leone with the specific focus on epidemiology and clinical issues. So Daniel is a Sierra Leonean medical doctor specializing in internal medicine. He has a strong focus on infectious diseases and HIV medicine, and plays a key role in providing clinical and public health services in his infectious diseases unit at Connaught University. He supports clinical research in areas including HIV, antimicrobial resistance, and infection prevention and control. And he is also currently a co-investigator on the REVIVE trial. His work in HIV medicine has been strongly linked with reducing the burden of advanced HIV disease in Sierra Leone. So I just want to say thank you so much, Daniel, for joining us today. And I will hand over to you. You can go ahead and share your slides.
Thank you so much, Keisha, for this very great introduction. And thank you also, Graham, for the update. And welcome everyone to this session. I'm very much pleased to be with you here today. It's a very great opportunity to look at this very, very important topic. In between the presentation, Dr. Suleiman Lako, who happens to be our national leader for the REVIVE study in Sierra Leone, will be coming in to give some comments, or maybe after, take some questions. So we're looking at the epidemiology and clinical issues around HIV in Sierra Leone. So our presentation is going to look at the background, looking at Sierra Leone, the health care delivery services. Also, we are going to look at the history of HIV and the current epidemiology of HIV in Sierra Leone, and look at Connaught Hospital, which is the main referral hospital in Sierra Leone. And also we look at the burden of HIV at Connaught Hospital, and also advanced HIV disease priorities in relation to Connaught Hospital. Sierra Leone is a very small country, but very mighty, which is located in the western part of Africa. It has a population of 8 million people, and like many other countries, the health system architecture composed of the primary healthcare system, secondary and tertiary. In total, these primary, secondary, and tertiary facilities contribute a total of 1,616 facilities. Some of these facilities provide HIV services, which include ART and testing services. And so now we look at the history of HIV in Sierra Leone. So it was in the late 80s, after the world understood that the pattern of HIV in the world, which was understood in the early 80s, it was around 1986 that in Sierra Leone, we established what we call the National AIDS Committee, with the aim to strengthen activities which include preventive activities of HIV. So these activities actually started in 1986. And in 1987, the first 10 cases of HIV were diagnosed, and this was reported among commercial sex workers. And it was also after that discovery of those 10 patients that the government thought it fit that they have to move, step up the program, which they set up the National AIDS Control Program, which is in existence to date. This program was established in 1988, and it's under the Ministry of Health. So a lot happened between, a lot didn't happen actually between 1988 to 2000. This was because Sierra Leone had civil conflict, we had war and political and instabilities within those periods. So,
hi, Daniel, I'm sorry to interrupt. We're not seeing your slides move, so I'm not sure if it's possible just to make them full screen.
Sorry, come again.
Daniel, your slides are not moving. So we're stuck on slide number 3. If you can make it full screen, maybe that will help.
So, is it moving now? Sorry, please.
No.
Not yet. I think, Daniel, maybe just check that you have the correct screen shared.
Okay, sorry. I think it was not the correct screen, please. I'm sorry about that. Sorry. Okay, so is it moving now?
There we go. Yes, it is.
Yeah. Sorry about that, please. So as I was saying, we had issues which included political instability. But after the war ended in 2002, the Office of the President established the National AIDS Secretariat, This National AIDS Secretariat is directly supervised by the president, and it is in the president's office, which with the aim to provide strategic leadership in HIV programs in Sierra Leone. So much has happened. After 2000, partners have come in to support the program. Partners including Global Fund come in to provide support. And also we saw in 2006 the establishment of the first ART center in Sierra Leone, which is where I work at Connaught Hospital. This is where the first ART center was set up. So this is a historical overview of HIV. So the current national estimate, as of now, we have 1.7% of our population in Sierra Leone who are living with HIV. These include 242,000 of our population, majority of whom are female. Also, we noted last year, 2023, that 3,345 new diagnosed new infections were noted. And also the deaths related to HIV also is 1,834. So this slide just gives us a picture of the current situation of HIV, including new diagnoses, the prevalence, and also the AIDS-related deaths that have occurred in the year of 2023. So it must be noted that since key population's contribution to HIV is key, let us have a view of the population and also the prevalence of HIV among this population. So we noted that the total key population is around 194,762, which is 2.4% of the population of the country. So a total, as you can see on the side, most of the majority of this population who are tested positive are the female sex workers, and followed by the MSM, the men who have sex with men, and also this is followed by people who inject drugs at 4.2, and also the transgender. And the list there is the MSM, which is at 3.2. Sorry for that. And also, it is also noted that people in correctional center have high prevalence. So these give contributions to give the most contributions to the national population of people living with HIV in Sierra Leone. Sorry. So this slide gives a picture on the improvements that have been made in order to meet the 95% target of the UN/AIDS. So currently, 83% of the total people living with HIV in Sierra Leone know their status, and 83% of those that know their status are on ART. And we have provided services in eliminating mother-to-child transmission at a rate of 87%. Where we are lagging behind is the suppression of viral loads. The virally suppressed people are still 65%. So this is a picture of what is happening. So this map gives us a geographical distribution of areas that are more prevalent, where we have more prevalence. So one of these areas is the western area, urban and rural. So western area, urban and rural, where the capital city, Freetown, is, contributes the highest number of HIV cases. This is as the pattern goes on in other places. It is not a surprise because in urban areas, we have more activities and more population in these areas. So this is not a surprise. We have other areas which also share some high percentage, including the second city and also other places. But more prevalent, HIV is more prevalent in these urban areas in Sierra Leone, including the western area and Bo, which is the second capital city of Sierra Leone. The number of facilities, as we in the other slide, we noted that the total health facilities in Sierra Leone is 1,616. And most of these facilities provide HIV services. These services can be either ART or testing. It can be both testing services, ART, or just testing services. And the percentage of those facilities that provide these services is at 59%. There are some districts in Sierra Leone who have been supported. Some of these facilities are being supported by partners, while some districts, the facilities are not being supported by partners. They are just the government National AIDS Control Program, which provides both technical support to them and also support in order to carry out the HIV program in these facilities. Currently, we look at this approach to conduct testing for our patients. Either the client-initiated testing and counseling, provider-initiated testing, counseling, index case, and the community-based, which can be done with outreach to communities and also HIV self-testing, which you'll be given the opportunity to do your test. And in all these confirmations, when confirmation is made, the people will be included in the national register and ART services provided within the shortest possible time for this. So this slide is a bit scattered, but it is what gives us the view of the amount of the first bar here gives us the total tests that are being done between total positive tests that are being done between January to June this year, 2024. And it's also the second gives us the index case that are being offered tests. So if you look at the index case that are being offered tests and the index case that are accepted the offer, it most like majority, it's only like very few that don't accept. Majority of the index cases that are offered the test in these our facilities, our testing facilities accept the test. So this is a very good one for the services that are being provided. And where we are having challenges is this long one, which are the contact elicited, and the one after this long bar is the people that accept, the contact that accept the test. So we are still having challenges as a national program with having all the contacts of the index case to be tested. As it stands, we are improving the people that are being tested to care also is also being improved. So index contributions to HIV testing. So we are moving currently from 2022, the first quarter of 2022, it was down at 2.7%. And currently it is 16%, though we have some times that we have moved up, but it's still the index testing contribution to HIV testing is still moving up the ladder. And also, we have seen great improvement in the positive contributions of index. So it was in 2022, first quarter of 2022, it was 10.5%. And currently we are at 35.5%. So that is also a great improvement into the total testing index contribution to HIV testing in the program in Sierra Leone. So this is a survey that was done to look at provider-initiated HIV testing and counseling in Sierra Leone, and with event actions like quality improvement approach. We saw a great improvement after this approach from 4% within a year to 95%. So these quality improvements and approach are very, very great and contribute greatly to help provider initiative and initiated testing and counseling, which is the case of this study that was done here in Sierra Leone. So this gives us a view of the age within the age group of people being offered tests, and also the sex. So we see that between 15 to 49 to 50 years is where most of these are patients that are tested lie between these age groups. And also the female number is above the male number in terms of distribution. So this gives us that picture of the testing yield by age and sex. And this does not include ANC data. These are the ANC first ANC testing positivity rate among our patients. It's noted as highest rate is the Western area. Rural noted 23%, which contributes to the highest positivity rate in first ANC testing positivity among our patients. This strategy helps us to prevent or to eliminate the mother-to-child transmission, and with this increasing in this testing gives us the opportunity to prevent these transmission at that level. Looking at Connaught Hospital. Connaught Hospital is the main referral hospital, national referral hospital in Sierra Leone, and it's have a very high burden of HIV. And in a study that was done in 2019, we noted that a positivity rate at Connaught Hospital is 24.3%. And this includes patients in both the medical wards and patients in the surgical wards that we are tested at that time. So it is huge and high, and these hospitals have challenges in terms of resources in meeting all these cases of positive patients. This is where I work at this facility. We have a structure, we have all the structures that provide services, though sometimes we have been challenged, but we are within the limits to provide the services that we can for the people. Yeah. So as we have noted before that the positivity rate is high. So in admissions of patients, medical admissions of the patient that we admit in the medical wards, it is higher. So if you look at the general wards, all the wards, including the other places like the outpatient department, it is at 14.8. This was in a study that we did in 2020. We are quoting Dr. Suleiman Lapo. They noted that advanced HIV is really an issue among these medical admissions. So as 40% of the medical admissions were HIV related, 69% of these medical admissions had advanced HIV. And this was the based on the CD4 of less than 400. So we based this classification based on the CD4 level of less than 400. And out of these advanced HIV disease patients that we are admitted, 34% were new diagnosis. They have never, this was their first time to know that they have the HIV disease. And we further went on to look at the cryptococcal antigen among these patients. And we also noted a positivity rate of 4.7% of these patients with advanced HIV disease had a positive cryptococcal antigen. So advanced HIV is a burden at Connaught Hospital. It contributes to a total of 31%. So 31% of the major mortality, cause of major mortality in this as a result of advanced HIV. So we are still moving to see how we can reduce this mortality, and also programs directed to help patients with this high number of patients with advanced HIV disease in Connaught Hospital. So we did a recent study as of 2023. This we sampled people within the ages of 15 to 24 years. And we noted that 40% of the patients that came, this was at Connaught Hospital also. We looked at both the outpatient and the inpatient. And we noted that 40.9% of the people living with HIV that presented at Connaught Hospital within a period of 6 months, they are between the ages of 15 and 24 years. And interestingly, we noted that also out of this percentage of people, that 41.6 had advanced HIV disease. So as advanced HIV disease in Sierra Leone is a burden to people that are presenting, that are being admitted, it's also a very great burden to young people between the ages of 15 to 24 years that present for care either at the outpatient department or at our clinic, or for admission into the wards have this advanced HIV disease. We still struggle providing care based on limitations, which include limited diagnostic capacities, though we saw some great improvements this year because partner support. But in the previous 2 years, we had a situation where we had CD4 challenges. We cannot do CD4 for months. So, but now those are behind us. Now we hope that moving forward, all those challenges will not be covered. But we still have challenges with viral load. I think for the past 1 year or close to 1 year now, we have not done viral load. This is not just at our center in Connaught Hospital, but generally in the country, we are very, very limited, and we are very limited with viral load because the private people that offer these tests, it's very costly, and most of these our patients cannot afford. So we also face challenges in limited resources to manage opportunistic infection. These patients, when diagnosis of some of these opportunistic infections, supporting the management, it is very much challenging, providing treatment for patients that cannot afford it. And so these are all things that contribute to high mortality, as we saw back in other slides in the country, also in our site, in our setting at Connaught Hospital. But so now we look at this broader look at this challenge. We're looking broadly, as we mentioned before, other things like linking to treatment services. It's sometimes a challenge, but this one is not as a result of sometimes it's as a result of the patients themselves, and also linking them to services with the capacity that we currently have. It's also a challenge because in terms of personnel, reaching out to people, in terms of people acceptance, these are all what contributes to challenges in linkage. So like I mentioned before, stock out of commodities. We had those challenges, but in the past 6 months to 1 year, we have some improvement, like the CD4 count. We still have, and also, but still we still have challenges with provision of viral load in the country. We still have limitations or limited integration of services, other services into the care. You know, the impact of public health emergency has also contributed to some challenges. These include the Ebola in 2014, 2014 to 2016. The Ebola outbreak then disrupted the healthcare system, which also affected the linkage of our patients and providing care for our patients. So other challenges, including stigmatization, including limited skills to manage, analyze, and utilize this data, are being faced nationally in Sierra Leone. So we look at this priority for advanced HIV disease as part of our plan, and partner supported. We have some other programs that we are hoping partners will come in place to support HIV, advanced HIV. So among these priorities include to screen advanced HIV routinely This includes the availability of the tools including quantitative CD4 counts, and also strengthen community systems. These systems will improve linking patients to care and also improving in adherence of medication of patients to ARTs. And another very key important component is strengthening referral services, which will also enhance the management of advanced HIV disease, and also this strategy will enhance the diagnosis, the screening of advanced HIV disease, and also helps in the management of advanced HIV disease. So currently, the REVIVE project, the REVIVE trial, which is, we have 6 proposed sites in Sierra Leone. These includes most of the regional headquarters in Sierra Leone, including Western area. We have proposed sites in all these areas. The REVIVE trial for us in Connaught have helped us to provide that link between the caregivers and also the patients. With the routine call that we make to the patients, it has been helping us to link our patients. But for these ones, the patients with advanced HIV disease, the ones that have CD4 less than 100 that are being recruited into the HIV the REVIVE study, we provide all these linking services. We have other programs like the Impact for HIV, Global Fund, and CHAMPS, which are also aiming at providing the much needed services, providing proper referral systems for HIV. And for the Impact for HIV, we will have Connaught Hospital as the hub. Their diagnosis and the management, they'll be providing support for the management of advanced HIV. Also, Global Funds, also CHAMPS also will also support in the management of advanced HIV disease, which is a burden in our setting. And we come to the end of this session. I want to thank everyone for joining in this session. I want to thank you all and organizers, and also the REVIVE team. It is very much, and we are very grateful from Sierra Leone. I am very grateful, and also our national leader, Dr. Suleiman Lako, is also very much grateful. So this is the end of our presentation. We'll invite any questions and comments. Thank you all.
Thank you very much, Daniel. I think that was a really great talk, and it gives us some special insights into the conditions surrounding advanced HIV disease in your country. So thank you very much. If we have any questions, you can just either raise your hand or you can put them into the chat and I'll read them out for Daniel.
Keisha, it's John here.
Yes.
Thanks. If I could ask a question, and Daniel, do you have thanks very much. Really, really fascinating. Do you have a sense as to the changing burden of HIV over time? In other words, compared with 5 years ago, do you think that the burden is increasing or remaining stable, or are there data even available for that? Thank you.
Thank you very much, John. So according to data, available data, so relatively, it has been relatively stable. But from 2008 to 2016, to 2019, so it's changed from 1.5% to 1.7%. So there have been some amount of increase in the burden of HIV. So yes, there has been increase, but at a very, very stable rate. Okay.
Great, thank you, thank you.
Thanks, Daniel. Graham.
Thanks very much, Daniel. After your talk, I've got a much better idea of the landscape of HIV and the challenges faced in Sierra Leone. One of the things that strikes me is your teams working on the REVIVE trial have enrolled a very large number of people with advanced HIV disease. In fact, at just 2 sites, you've enrolled 284 participants since the start of the trial, and clearly a lot of work has gone into enrolling those participants. But I'm just interested as to why you are still seeing so much advanced HIV disease in Sierra Leone, and your thoughts about the reasons why there's still such a high prevalence of advanced HIV disease. And perhaps, to add to that, what is access to antiretroviral therapy like? Is it free of charge? Is it easy to access? Is it easy to access ART without interruption?
Okay, thank you so much, Graham. Yes, as the data shows, advanced HIV is still a challenge. The healthcare system in Sierra Leone, because of the most of these patients are not being on regular medication. So we see that some amount of them are new because we have late diagnosis of patients. So most of like 30% of the ones that have been diagnosed with advanced HIV, even at the time of diagnosis of advanced HIV, they were new. So like those 30% they didn't know their status until they presented with advanced HIV disease and been admitted. So because of the challenges in the healthcare system providing services, we have limited places that provide services to these patients, to our patients, and nationally. So this is one of the reasons, and I think much needs to be done in order to improve testing of patients. Because if we don't improve testing of patients, patients will be coming in the late stage and with advanced HIV disease. So it's still a challenge. And also, few of these patients are known patients who because of things like stigmatization, self-stigmatization, or they will be defaulting from their services, from HIV, ART services. So defaulting late diagnosis is one of the reasons, and also patients that already know their status but are not taking their services. For the ART services are free. Since the initiation of ART services in Sierra Leone, they are free of cost. So you don't need to pay to receive ART services. So there are few times, but those times I've not even witnessed more than a month that we don't provide ART services for our people. So like most of we provide free ART services for them, and it's also we have centers right across the country, all over the country where these services. It's only that people present, and that's also we can look into the cultural beliefs of our people. Some of these conditions, opportunistic infections here, when they have them, they will think that, oh, these are related to these traditional things that they will call, which the first point that they will go is to maybe to herbalists, to seek advice. Only when they are failed to see the improvement of this patient, then they will come and seek medical advice. These are traditional. One is the late presentation, and our cultural beliefs, traditional beliefs that people think that most of they have conditions like herpes, when and shingles, when people have it here, they say it's related to a devil. The devil have just touched them. So that's cultural beliefs. Well, improving this system, I think, will help us to meet this which needed to bridge this challenge in reducing the burden of advanced HIV disease in Sierra Leone. Thank you.
Thank you.
Thanks, Daniel. We have a question in the chat from Kemi. She asked, do patients need to be seen at a referral center like yours before they can get ARVs? And she also asks, the drugs and testing are free. If you can please clarify if there are any other additional user fees to access care in the clinics.
Okay, so I give the initial slides in which I noted the primary, secondary, and tertiary facilities. So HIV services is being provided in all these levels, primary, secondary, and tertiary. So they all provide, some provide testing, but majority provide both the testing and also ART services. So it's not just at the referral site, but down to the primary care level, they provide this care to patients with HIV. Yeah. So, and we asking about, is it the drug testing services?
She asked, she understands that you're saying the drugs are free,
Yes.
And testing is also free, but are there any other additional costs to access care in the clinics?
Okay. So in Sierra Leone, and she presents to the HIV clinic, and you don't need to spend anything. You are given laboratory investigations are being done free of cost. In my own center, referral center, we have our laboratory there where we do all the tests. And also sometimes we are being supported by partners who provide support medications to patients with opportunistic infections. Though sometimes it's a challenge. Yes, I agree. It's a challenge because not all of these services are available sometimes. Sometimes patients have to go to do them outside because of the challenges that we're facing in this center. But for the services that we provide, there is no cost attached to them. They are free of cost. Yeah.
Great, thanks, Daniel. Kemi also asked one more question. She asked, do you have a PrEP program?
Yeah, so currently we have a PrEP program which we give with this key population and also the partners so we provide, yes, PrEP and PrEP services is being provided for and the key population and also people at high risks of HIV. Yes, it's part of the national program.
And Daniel, just in your experience, those PrEP programs, are they well utilized?
So for me, I think it's still a challenge. It's still a challenge. Looking at the fact that the burden among key population, it's the PrEP. Sometimes it's not available, and so it's still a challenge. It's still a challenge.
All right, thanks, Daniel. Are there any other questions? Graham.
Yeah, Daniel, one more question. You mentioned in the medical wards, the mortality was 30% related to HIV. And I understand that there's challenges with diagnostics, but just from your perspective as a clinician, what do you think the major causes of those deaths are?
From my own experience, patients that are presenting with advanced HIV, one of the highest is tuberculosis, be disseminated tuberculosis is one of the key, and also meningitis. So from my own experience, most of the mortalities we have, so we have other people that have other things like nephropathies, HIV-associated nephropathies, but among those, the CNS opportunistic infections, the Euro-AIDS is the highest. Though we still face challenges in establishing, because some of these patients, we don't know if it toxo, though we do cryptococcal antigen test, but we have not done much to see the pattern. We are still limited, but most of these mortalities that we have are associated with HIV, CNS opportunistic, CNS OIs. So yes, that is from experience.
Yeah.
Yeah.
And did you say the other was pneumopathies?
Okay. In other things like nephropathies, HIV, nephropathies, yeah. So it's challenging. So when patient comes with renal failure, meeting the demands to get them dialyzed and all these other challenges, it's very much difficult. Yeah. So these are things that contribute to mortality. But from experience, it's more the CNS that contribute the largest number of patients. And sorry, the mortality among these patients.
Thanks.
Thanks, Daniel. There are no more questions coming through the chat. So I think we can close off here for today. Daniel, thank you again for your talk, for your presentation. It was very, very interesting and very insightful. So thank you for your time. We appreciate it. And thank you everyone for joining us here today. Please do look out for our next Revive seminar, which will be in about a month's time. We will send out invitations again. So please just look out for that. And thank you again very much for joining. And we will see you all next month. Thanks, Daniel.
Thank you.
Thanks, Daniel.
Thank you very much. Thank you, John. Thank you, Keisha.
Goodbye, Daniel.
Goodbye, Daniel. Thank you.
Thank you.